Guide, which is organized by the Ministry of Health in collaboration with Kenyatta National Hospital and the University of Nairobi. My name is Dr. Janet Karimi. I work for the Ministry of Health. I head the Reproductive and Maternal Health section of the Reproductive, Maternal, Newborn, Child, and Adolescent Health Division. So I'm very happy to welcome you all here this evening, and I'm seeing from the chat we have representation from healthcare workers, health managers, trainers, researchers, and partners from all the counties. So again, this is to welcome you all as we come together to strengthen our understanding of the Labor Care Guide. This is a tool which was developed by WHO in 2020, but has been adapted by the Ministry of Health in Kenya in the current national guidelines on quality obstetric and perinatal care. The Labor Care Guide is essential to improving quality of care and safety of both the mother and the newborn during the delivery process. And we hope that this webinar will shed light and prompt you to take it up in the use to improve quality of care for our mothers and our newborn. I want to briefly introduce and also welcome the panelists. Thank you very much to all the panelists and facilitators. We are honored to have from the Ministry of Health, Dr. Edward Serem, who's the head of the division of RAMCA. Also to welcome Dr. Lois Nyanjao, who is the program manager for the maternal health program and has coordinated this event. From the University of Nairobi, we welcome Professor Zahida Qureshi, an associate professor in the Department of Obstetric and Gynecology, and also a teacher to many of us here. We also welcome Dr. George Gwako, senior lecturer at the Department of Obstetrics and Gynecology. Kenyatta National Hospital, a warm welcome to Mr. Benson Yankuru, who is a registered nurse and midwife, and also to Mr. Jackson Otanda, also a registered nurse and midwife. Facilitating the session, we'll have Dr. James Amenge, who is a consultant obstetrician and gynecologist at the Kenyatta National Hospital and a co-convener of the Intercounty MPDSR initiative. So a warm welcome to all of you, again, all participants, all facilitators, and all panelists, and thank you for joining. A few housekeeping rules. This session has started now and will go up to 8:30 p.m. Please keep your device, your laptop or your phone on mute during the presentations. Please share your questions and reflections on the chat, and your questions will be answered as the session goes on. And there's also an additional Q&A session after the panel discussion. The webinar is CPD accredited, and you'll get this after the session. So without further ado, to officially open the session, I want to welcome our head of division of RAMCA, Reproductive, Maternal, Newborn, Child, and Adolescent Health, Dr. Edward Serem, at the Ministry of Health to give the opening remarks. Dr. Serem, over to you. You're most welcome. Thank you.
Thank you very much, Dr. Janet. And I want to take this opportunity to thank all of you, to thank, first of all, the panelists who are going to do several presentations on this chapter on labor guide. So yes, as a country, yes, we know several countries have moved from a pantograph to labor care guide, and therefore we have had several discussions on this, and say therefore if the labor care guide is a better version of the pantograph, then as a country we should not be left behind. And that is why we initiated this discussion and said, how then can we further this discussion and how can we move forward? Because our interest is always to continuously improve the quality of care for our women and our population in general. So this is part of processes of improving the quality of care, the ones which which is offered by the healthcare workers to the population. So that is actually our task, and therefore this is now the purpose of this. From here, we would like, we will gather your views on what will be the next steps, because as a country we have to agree. Now that we have experts here from University of Nairobi and even Kenyatta National Hospitals, and I want to thank Professor Qureshi and the team for leading this, because it is part of their tasks to make sure that new innovations, new guidelines are incorporated into the national programs and more so on policy. Of course, we know, therefore, as a country, we will therefore have to take that step. So with all those, there will be several procedures. Several processes which have to happen, and therefore, that is now why we are bringing everybody. Most of you, the experts here, for this discussion. And I want therefore to end there, and I want to thank all of you for joining. And I want to give straight away, because we don't want to waste a lot of time, to the panelists to do their presentations. Back to you, Dr. Janet.
Okay, thank you very much, Dr. Serem. Before we go to the panelists, I'd like to invite Dr. Lois Nyanjao, the head of the Maternal Health Program in the division of RAMCA, to take us through the objectives for today's webinar and later hand over to the moderator to take us through the panel discussions. Over to you, Dr. Lois.
Thank you, Dr. Janet, and good evening, good morning, good afternoon, everyone. Welcome to this webinar, and I believe our task today is really to learn, and so our objectives are not many. The first objective is to appreciate from our panelists or our facilitators the overview of the labor care guide. And once we get a general understanding of what this tool is, we then learn from KNH and University of Nairobi on their journey for transitioning from use of the pantograph to applying the labor care guide in their routine services in the maternity. So essentially that is it. Today we are here to learn as we embark on the journey of rolling out this critical tool across the country. So let us engage. Feel free to chat, put your observations, your comments, or your questions in the chat, and we will respond to these as fast as we can. Asanteni, over to you, Dr. Amenge.
Thank you. Thank you so much, Dr. Nyanjao and Dr. Karemi, as well as Dr. Serem, for the remarks that you've made. Just allow me to equally acknowledge the presence in the panelist team, Professor Alfredo Sotti and Dr. Philomena Owende, the head of the Department of GYN NH, who will also be participating and sharing the insight from KNH experience. Without further ado, ladies and gentlemen, we are honored to have a team of experts who have been very instrumental from not only the development, but also the trial component of this tool. And who is better placed to really give us the insight, the content, and demonstrate actually how this tool can be utilized and be useful in helping us to overcome, to improve the quality of labor care within our borders. Dr. Gwako, you'll allow me to hand over the mic to you so that you can take us through the whole team on the content and even to the demonstration, after which you will hand over to Dr. Wende to share with us the KNH perspective later on. Dr. Gwako, over to you.
Thank you. Thank you, Dr. Menge, and good morning, good afternoon, good evening, everybody. So the task we have ahead of us is actually a lot. We have a lot to share. Thanks a lot for the opening remarks from Serem, Karimi, Lois, and everybody that has spoken. So for the next few minutes, we will try to answer the questions that Dr. Lois Nyanja has asked us to. So we will take us through how and why the labor care guide was developed. We'll be taken through that journey by Professor Qureshi. She's been part of the old pantograph and also now the new generation pantograph that we are calling the labor care guide. After that, I'll take you through the sections of the labor care guide. I'm sure you are really interested in seeing what is new. How does this new tool differ from the old pantograph. Number 3, we will take you through how the pantograph, the next generation pantograph, the labor care guide, is used, with examples from Kenyatta National Hospital. Will be taken through that session by Otonda and Nyankuru. Prof. Osoti is on the background, will be assisting us with the Q&A. And then as Amenga said, we'll also get experiences from Kenyatta by the head of department, Dr. Wende. So without much ado, I want to welcome Professor Kureshi to take us through the first session. Over to you, Prof. Kureshi.
So, good evening, everyone. Thank you for giving me this opportunity to make this presentation. It's a pleasure. I have known this tool for a very long time, so I am excited to share the journey of its development. I will try my best to project, and if I fail, then my colleagues can help me. So what does it say? Replace current share. Can my screen be seen?
Yes. Yes.
Okay.
Success.
Fine. So
Good.
thank you. I'm just going to take you through the process of its development. And the development started from what was a study done by WHO as far back as 2015. It's called the BOLD study or project. It was the WHO Better Outcomes in Labor Difficulty project, which was innovating to improve the quality of care around the time of childbirth. It was conducted in Uganda and in Nigeria. And what they found from it is what was used to decide that we need to make a move from what was the pantograph with all its lines and its transfers to what we eventually ended up coming up with. So what was recognized was that active labor should not be diagnosed until a woman's cervix is 5 centimeters. You remember the old one was 4, 3 and 4, and that the active phase should not be longer than 12 hours in the first labors for nulliparous and should not be longer than 10 hours in subsequent labors. In that BOLD project, they had actually reviewed like millions of, progression of labor through the monitoring that had gone on. And it was also felt that a minimum cervical dilatation of 1 centimeter per hour throughout the active phase is unrealistically fast for some women and is therefore not recommended for identification of normal labor progression, provided everything else is normal. So for pregnant women with spontaneous labor onset, the cervical dilatation rate threshold of 1 centimeter per hour during active first stage, as depicted by the pantograph's alert line, is inaccurate to identify women at risk of adverse birth outcomes. What was felt that the next generation pantograph should ensure that the practitioners undertake regular observations during labor to identify any emerging complications in the mother and baby that will trigger a corresponding line of actions. And it should have a reference threshold for what the abnormal observations are that should trigger that specific action. And constantly be able to remind providers to offer good quality care throughout labor to improve the overall experience of childbirth care, minimize over and under diagnosis and treatment for the mother and or baby, and ensure that the situation of the laboring mother and baby, which is positive or negative, can be rapidly and clearly communicated effectively to other healthcare providers and facilities. So amongst providers as they are taking care of or as they are referring, and support audit and quality of the care improvement processes. So who are the end users? The healthcare providers working at any level of care, whether it's primary, secondary, or tertiary, but the plan of action will vary depending on the level of care. and all women, regardless of the risk status, but recognizing that specialized care needs to be given according to the local protocols, depending on the high risk nature of the woman's care. So the development went through these processes that I have listed here. The first one was a consultation with international experts in intrapartum care, and this is where I participated. This was held in April 2018. Following that was a qualitative study, and the participants were from Africa, Europe, and Asia. Then was a technical consultation, which was done in 23 countries. And then it was followed by a usability test in simulated settings. And this happened in Brazil only. And then eventually the evaluation of the labor care guide in clinical settings, which were 6 countries where we participated. So this, as I was explaining, the first part was a reevaluation and update of the current design of the partograph. And it was based on the WHO 2018 recommendations on intrapartum care for a positive birth experience. And then the qualitative evaluation, there were 43 participants, focus group and individual interviews in 6 countries. Then there was the online consultation in December of that year. There were 110 respondents from 23 countries. And then the usability, which happened in Brazil. And this is now the last part where we come in again. This was the usability, feasibility, and acceptability testing, and this took place in October towards December 2019. And it was to evaluate the usability, feasibility, and acceptability of this labor care guide among maternity care providers. So 6 countries were chosen. We were one of them. So Argentina, India, Kenya, Malawi, Nigeria, and Tanzania. And each country had to pick 2 hospitals. So that came to 12. We picked Kenyatta National Hospital and St. Mary's Mission Hospital. So what happened in this phase for all the 6 countries? 142 providers were trained and 12 hospitals across these countries participated. Each provider completed a questionnaire after the training to tell us their views of how they felt. The next phase of these were that they had to screen women in labor wards. So we had to get 10 healthcare providers for each hospital, and each of them had to take 10 women through labor and monitor with the labor care guide. So overall, 1,268 women were screened, of whom 1,226 were recruited, and the labor care guide was applied during that process of labor and delivery. And they collected information of each of those birth, the maternal characteristics, and the maternal and baby outcomes. And at the end of using that partograph and completing the delivery, the provider had to complete a postpartum questionnaire rating their experience and suggested improvements with this labor care guide at that birth. Because each birth, they may have a different opinion depending on what happened. Phase 3 was that there were 12 FGDs with providers. So each facility had 1 FGD conducted on the usability, feasibility, acceptability, barriers, and facilitators, and to suggest improvements. And there was the questionnaire was rating usability, satisfaction, and suggested improvements. So what did we get out of this? So the 142 providers, most of them were midwives. Well, 2/3 were midwives, 1/3 were doctors. Overall, they said they found the training helpful. They felt they could use the labor care guide in the next day. The women were general population, and 90% of them had a vaginal birth out of the ones that were monitored. So what were their experiences? They said they were very happy. You see the rates are between 98, 94, 91. They found it useful. They were satisfied. They were able to complete it. And they were very satisfied with the design, about 80%. So out of the providers, the type of provider and the women's parity, there was no major difference. And these are the various sections which when Dr. Soti and team come in, they will take us through. But you can see generally for all the sections, the providers agreed or strongly agreed about what they felt of that. And overall satisfaction was 75%. So you can see it ranges from the lowest was like 66 and the highest was 83. So generally very well accepted, and they were happy with it. So just to share very quickly, these quotes in the FGDs are from all the countries. So they say we show more care to our patients, we have less complications, and we have less interventions. It helped me to detect some of the things that usually I would not do well with normal routine. The labor care guide provides us to provide support for person-centered care and strengthen the relationship between the providers and women. So they said it had an influence on a holistic view of the patient. They said there was effective source of information that was precise, coherent, and relevant. Others said they were able to evaluate what they needed to do to make changes. And they felt it was really useful during the handover because we are able to work as a team, because the next person who is taking over from you is going to continue from where you stopped. Although it is time consuming to record all that, overall this can reduce the provider's overload by reducing unnecessary interventions. And also they felt that if you used it and you reduced your interventions and the woman delivered vaginally, then you would have less women being taken through, cesarean section, and that would reduce the care you needed to provide. So whereas you have to sit for a long time, it adds to your workload, but in the long run, it reduced our workload. And I'm sharing those quotes are from all over those 6 countries. These are quotes specifically from our country. And the provider said after the first day, things started getting easier and even enjoyable after a week. It helped me to detect some of the things that usually I would not do well. I think it is supported because during the handover, you can report exactly what happened. For example, the mother had meconium, where you've put an alert and you tell the staff who is taking over so that they can decide what the action will be. Time and workload, they said, the staff patient ratio, of course, does not make it very easy. We have many mothers, and now we want to imagine that we want to manage these mothers if they are over 50 and maybe we are understaffed. So plotting needs a lot of time. You have to be very keen. Equipment, they say you have to have things. Sometimes you don't have a clock in our labor ward, but I'm sure that doesn't happen now. There's a lot of monitoring. This is how monitoring the mother and using labor care guide is. For example, the temperature, pulse, blood pressure, we need equipment. So if you're in a facility that don't have this, then you cannot do that accurately. So we must make sure that you have all the equipment. So the companionship came up that, in our facilities, we are not allowed we are not in a conducive environment to have companionship. So that also is something that needs to be looked at. Somebody says the labor care guide was fun because you just have to write. On the other side, it has a lot of writing and doesn't have shading of the contractions. You just indicate the number. But on the other one, you had to shade all those contractions, but then says, okay, there was a lot of writing to do. So this was a mixed feeling by this person. So what were the results? There were some concerns about the size, the increased concentration of what you have to put in, increased time burden, and maybe requires specific adjustments, and look at the concerns. And there were some constraints on the impact of the labor care guide because at that time it was so new, and that you might require complementary actions to enhance the supporting care. So the main conclusion was that it is feasible and acceptable to use across different clinical settings and can promote woman-centered care. Some design improvements would probably benefit usability. The implementation needs to be accompanied by training and supportive supervision, as well as strategies to promote an environment that is enabling, which includes updated policies on supportive care and ensuring that all essential equipment is available. This is a paper I'm sharing, which is a FIGO position statement on the use of the labor care guide versus the partograph. This was released as recent as 26th of April 2025. You can look for it if you wish to read the whole article. And finally, FIGO has endorsed it and said the labor care guide is a transformative tool designed to enhance maternal and fetal outcomes by integrating evidence-based respectful care during childbirth. And FIGO supports it, and they made that whole statement. So they feel at the end that it should be adopted. So the key recommendations were that there should be universal adoption as a standard tool for labor monitoring to support safe, respectable, and evidence-based childbirth care. Of course, there should be training for all those healthcare providers who will use it so that they understand its application. Facility readiness, of course, with regards to equipment and staffing, need to enable full implementation. You need to have respectful maternity care, so there should be policies around that. Monitoring and accountability, you have to look at quality improvement teams who should oversee this rollout and ensure that it's consistent use through supervision, audits, and performing tracking. And interim use of the partograph in setting where labor care guide implementation is not yet feasible. The traditional partograph should continue to be used until proper training and infrastructure are in place. So overall, we need to move, and I'm very happy, Dr. Sarem, after all this time we have finally reached here. I brought this issue up as soon as it was developed, but we are happy this is happening now. So Kenyatta National Hospital took it up, and we look forward to hearing the experiences. So we need to look at what else needs to go into it. I think the main thing here is the partograph. A lot of retrospective plotting used to happen, which really cannot happen here. So that is a very good plus point. So I think with that, I would like to end my presentation. Thank you very much for listening to me.
Thank you. Thank you, Professor Qureshi, for a very clear presentation. So I'll now take you through the sections of the labor care guide. I'm sure for those who've never used it, will be very excited to know how the new labor care guide looks like. Prof. Qureshi has already mentioned some of the sections of the labor care guide in her presentation. So allow me to project my slides. So just to recap, so that you're on the same page as I share with you the sections of the labor care guide and how different it is from the traditional partograph. Prof. Qureshi has already said that the journey to develop this new tool started a long time ago, but 2018 was a significant year in this journey. As Prof. Qureshi has already said, that's when most of the activities happened. And this is how many years, almost 7 years later, but it's good that we're here today. Now, among the other things that happened in 2018 is that the World Health Organization at the same time revised the recommendations on the intrapartum care for a positive childbirth experience and published 56 evidence-based recommendations. 30 of those were retained from the previous recommendations, and 26 recommendations were new. Some of them Prof. Qureshi has already mentioned, for example, the definition of what is active labor, the duration of labor, the duration of second stage, among other things. So the other thing that happened in 2018, which again Prof. Qureshi has already mentioned, is that the World Health Organization introduced the WHO intrapartum care model, how they envision a woman in labor should be treated. Now, this model is woman-centered. It puts the lady at the center, and it proposes 9 recommendations that have to be given as a package. Prof. Qureshi has already mentioned them. So there is a respect to maternity care. We have to give our mothers emotional support from a companion of their choice. Effective communication by the staff. We have to offer pain relief. We have to do regular labor monitoring and documentation of events, and also do audit and feedback. This has been mentioned. Unlike the previous era, so we have to encourage our ladies to take oral fluids and also offer them food, especially the low-risk women who are in labor. We don't have to deny them an intake of fluids or a meal. The next one is to allow for mobility during labor and to allow them to deliver using a position of their choice. When we were making this presentation last week, Dr. Serem, you are not here. So I'm sure once you adopt the LCG, women are going to come to your office to ask for bathtubs and jacuzzis for delivery on a light note. But it's one of the recommendations that was made by WHO in 2018, allowing women to deliver in a position of their choice. As the women come in for admission, you have to have a pre-established referral plan. You don't wait until things go south. That's when you're thinking about what is the referral plan. For example, if you're in a level 2, level 3, level 4, you should know that should you get a complication, where will this lady go? Then as they come in to labor, you also have to think about continuity of care, their postnatal care, linkages and all that. Now, for us to deliver these recommendations, obviously, the healthcare workers have to be provided with essential physical resources. You can think about the issues that were raised during the study about issues of space, for example, so that you can allow now the doulas and companions to come to our labor wards. The other thing that is required is that you must have competent and motivated staff to be able to offer this quality intrapartum care. So to accommodate these recommendations and some of the 56 recommendations that were put forth in 2018 by the World Health Organization, as Prof has said, then it was necessary or it was impossible to have all these things superimposed on the existing patograph. So it was necessary to develop a new tool that incorporates these recommendations, hence the labor care guide. So the labor care guide is divided into 8 sections. So 3 of these sections are new. Prof. Kresh will tell you that for Kenya, only 2 of these sections are new. The last one, birth outcomes, has always been in existence in our old patograph. So the first section, you'll be able to see where my cursor is on the identification and labor admission characteristics of the ladies as they come into labor. This is a section that was retained from the old patograph. The second section is on supportive care, where my cursor is. We'll be able to give you details of each section. The third section, where the cursor is on care of the baby. This was retained from the old patograph, of course, with some changes that we'll tell you about. The fourth section, where my cursor is on care of the mother. It was maintained from the previous patograph with changes. The fifth section is on labor progress, again, retained from the previous patograph, but with changes. Section number 6 is on medication. It was retained from the previous patograph with changes. Section number 7 is new on shared decision-making. And the last section down here is on birth outcomes, which is considered new for the rest of the world. But for Kenya, I think during the development of the old patograph, Prof. Creation team insisted that we had to have that section on birth outcomes. So for us, it is not new. So now I'll take you into the details of each section. So for section 1, where my cursor is, it collects basic data on the woman and labor characteristics, which include the name, the parity, labor onset. You write the date when the time and date when the labor started, when the active labor was diagnosed, when the membranes ruptured, and then, of course, the risk factors at admission. Section number 2 is on supportive care. So this is new. On supportive care, it involves recording of whether the parturient has a companion, whether she's getting some pain management, and whether she's on oral fluid intake, and also record what posture she's taking during labor. Yankuru will give us the details on how that is filled. Section number 3, where my cursor is on monitoring of the baby. So again, this has been maintained, but with changes. So over here, we record the fetal heart rate, amniotic fluid, fetal position, caput, and molding. Okay. The next section, section number 4, where my cursor is, again, it was maintained from the previous patograph. Over here, we record the maternal vital signs, the presence of protein and acetone in urine. But if you look at it keenly, you will notice that again, there are some changes. In the old patograph, I think we used to record our blood pressure using arrows, pulse rate using a dot. Nyankuru will give us details of how now this one is filled. Section number 5, and ladies and gentlemen, you can use the chat box and the Q&A section to post your questions. Professor is on standby to answer them, and some of the ones that will not have been answered will be able to answer at the end of the presentation. So section number 5, again, was retained from the previous patograph, but with changes. Section number 5 deals with the progress of labor. So it's intended for plotting the cervical dilatation and the fetal head descent. Section number 6, where my cursor is on medication. It has 3 rows. There is a specific row for oxytocin use. It has a section on other medicines that the patient might be on during the process of labor. It has a row that a specific row for intravenous fluids if the patient or the mother was on IV fluids during labor. The next section, section number 7, this is new. This is on shared decision making. It has 2 rows. So there's a row on assessment and the plan. So what is intended is that when you review a patient, so let's say you've looked at, you've checked the fetal heart rate, you've checked the contractions, you've checked the descent at a particular time. In the shared decision-making section, you have to give an opinion as to what you think your assessment is. You give some form of a diagnosis. For example, you can say it's normal labor, normal progress. That's assessment. Or there's a fetal heart rate deceleration, or there's meconium stain grade 3 or something like that. And then after that, then you have to give your plan, a shared plan, meaning you discuss these findings with your health, the team that you're working with. You share these findings with the mother and the family. Then you come to a conclusion. So you make a shared decision. It's not an issue of there is meconium grade stained grade 2 mama, sign hapa tunaenda theater. Just to be a shared decision making. So this is a new section. Section 8 collects basic birth outcomes. It's down here. So this again was retained from the from our old patograph. So this is where you record the mode of delivery, blood loss, neonatal status, the APGAR score, and birth weight. Now, the pathograph, as I said, has the 8 sections. It also has some elements that are cross-cutting through all those sections. Okay, so we have 4 elements, and these ones are in the columns. Okay, from my left, there's something in, I'm colorblind, I think it's in green, where my cursor is. That's the alert column. Then you have the timeline, where my cursor is. Then you have the stages. And then down here, you have instructions and abbreviations. I'll give you the details. So the first element over here is the timeline, because everything hinges on the timeline. So on the timeline, when a mother comes in, you are supposed to record the time in 24-hour format when this mother came in. So if it's 20:30, for example, like now. And then, of course, you're going to record all the other observations that you made along that timeline, just like in the old pathograph. So, but the change is that you are recording the time when you're doing the observation in 24-hour format. So that's the first element, the timeline. Second element is what you are calling stages, where my cursor is. So this has been, it's a new column, it's a new element, as I said. So you'll notice that the LCG, unlike the pathograph, has introduced a new column on second stage. So you have the first active stage. So the active stage of the active first stage, yes. And then you also have the second stage. Okay, this was not in the previous pathograph. Then the last element is the alert column. We are saving the best for last. So in the alert column, where my cursor is, so for section 2, 3, 4, and 5, there are some alerts that give you reference thresholds for abnormal observations that should trigger a prompt and specific action. So for example, if you look at supportive care, there are some alerts there. So for companion, there is an N. If the mother does not have a companion, that's a problem. For pain relief, if pain management is not being done, that is an alert. You have to do something. For oral fluid intake, if the mother is not taking that, that is an alert. You should be able to take some action. If the mother is maintaining a supine position, that is an alert, and you should be able to do something. For the fetal heart rate, Nyankuru will take us into the details. For the baby section number 3, so there is the baseline fetal heart rate, and for the labor care guide, we actually record the actual figure, not a dot. So if you picked a fetal heart rate and it's below 110, that is an alert. You have to take action. If the fetal heart rate is more than 160, that's an alert and you need to take action. If there is a late deceleration, that is an alert. You have to take action. If the amniotic fluid is meconium stained, grade 3, or blood stained, that is an alert. You have to take action. When you're assessing the fetal position and you find the baby is in occipitoposterior or occipitotransverse position, that alerts you to take action. Or if there's caput, 3 pluses, or molding, 3 pluses. When you go to section, the section on the woman, again, vital signs, if you found a fetal heart, a maternal pulse rate of less than 60, that's an alert. More than 120 is an alert, you have to act. If you have a systolic blood pressure of less than 80 or more than 140, that's an alert. Diastolic pressure of more than 90, it's an alert, you have to take some action, as opposed to previously, where you would plot, as we said, using the arrows, and then you do nothing about it. Temperature, the same. And also for progress of labor, there's an alert. So for example, if a patient is admitted at 9 centimeters cervical dilatation and there's been no progress in 2 hours, you should be alarmed and you have to take action. So ladies and gentlemen, as I said, there are sections and there are elements. One of the most important elements is the alert column, where once you take an observation, you record, and then you refer to the alert. If it meets the alert criteria, the LCG will alert you to take some action. The last element was on the instructions and abbreviations. I've talked of N's, Y's, T's, NO's. So all that is explained here, what a Y, what an N, what a D means. And it also gives you instructions. For example, under the instructions and abbreviations, you're being told that you're supposed to circle any observation meeting the criteria in the alert column and alert the senior midwife or doctor. And of course, you record that in the assessment and the action that is taken. So still reminding you to post your questions, comments, concerns in the chat box. We'll be able to answer them real time and also at the end of the presentation. So you'll allow me to now invite Nyankuru and Tonda to take us through how the labor care guide is used using the check, record, compare, and plan cycle, CRCP. Thank you for listening, and over to you, Nyanguru and Otonda.
Benson, if you're speaking, probably you are muted.
Thank you, Dr. Menge, and thank you, Dr. Wako and the entire team. Sorry, I didn't realize I was on mute, so here we go. Now, the experts have already explained everything that there is to know about this. So let me just go straight into I hope you can see my screen. Dr. Menge, you can confirm?
It's just about come. Yes, now it has. You
Very
can
well.
make it in slideshow, then you proceed.
Thank you. All right. So, so there we go. Now, I've gone straight here because I think Dr. Guaco has already elaborated what there is here. So now, allow me to just take you to this screen, this page where we have the actual paragraph and how it is filled. So now you have, look at this, the entries. This is an example, an illustration on how we are expected to fill the paragraph. So you can see we've used an example of a patient here, not a real one. to demonstrate what the care guide expects. So first, let me mention that this is a guide, and therefore, when we are using this guide, still we are expected that we employ our clinical judgment and clinical acumen to make decisions. So therefore, it's not anything cast on stone. So when we are using it, as we have said, as it's rightly named, is a care guide. So when you make entries here, it must remain that ultimately you have to make the decision. Now, so if we look at this section on supportive care, you would see that the entry made there, the first where you can see my cursor, is a no, an N which represents no, meaning this client did not have a companion. Now, where we are capable of providing a companion, maybe you have space and you don't have crowding of patients, you provide a companion of the patient's choice. The client may choose to be accompanied by their partner or to be accompanied by, a sister, or they could even choose to stay along in their labor with a preferred midwife. So that client should be made aware that all those options are available and that you can choose who you want. Now, the reason this one is circled is, as Dr. Wako has explained, anything appearing in this column over here, the alert column, is an alert value for every entry. Now, the entire thing down the line, and all the entries and parameters, the limits set in here, are alert values for each of the sections. The only section that does not have, as we shall see, is the section for descent, which does not have an alert value, and the section for medication, as we'll see later. But for now, this is what you do. So now you circle in red like that. If your answer is yes, that the client has a companion, you just make that entry and leave it there. So you do not need to do anything. Now, so if you make an entry like that, there is a section. Allow me to go down to show you from here. So you had entered, from the example I've shown you previously, you had entered an N and you circled down here. You can see here you say offer companionship. So you had circled in red to alert that there is a problem somewhere, and therefore what you are going to do is offer a companion. That companion, I've already explained what the options could be for the client. So now we go back there. This section, that applies for pain relief and oral fluids. So it's no longer the case that labor is painful and therefore we don't give analgesic. So analgesia is incorporated in the guideline of this care guide. And also the oral fluids and the other parameters. Now, so the options are a yes, a no, or a decline. You may see down here for oral fluids, you offer the client all those options. If the client declines your offer, in the spirit of respectful maternity care, you respect that and make that entry to show that you actually did make the effort of offering what is recommended, but then the client has chosen to decline. So make the entry with a D. That is for decline. Now, When it comes to posture, this is the position in labor. Dr. Wako has already explained to you that now we have to make decisions along with the mother who's delivering. And therefore, so the position we will see when it comes to the second stage, that the position, the traditional lithotomy position where we used to deliver women was comfortable for the person who's attending the delivery, but not necessarily for the mother. And therefore, with this recommendation, women can choose to deliver in a squatting position or on all fours or any other position that is preferred by the woman that makes them comfortable. Now, you may see here that SP is circled because it is appearing in the alert value again, in the alert column again. So anything that appears, if you make an entry that is either within the limits or that is a parameter over in the alert column, you are going to have to circle it in red and pick it as an alert. So here we've entered SP and circled, and you can see here it is appearing in the alert column. So supine position is not recommended because of occlusion of the aorta and the supply to the uterus where the baby is. So we make that and then advise on a better position. Now, for this section, the entry is either supine or any other. So the one that is an alert is supine. Any other position adopted by the mother is considered mobile. Now, you may write this or you write MO as an entry here. So mobile is any other position if they're in left lateral or they are ambulant walking about. That is a mobile position for the woman. Now, you come down to the baseline fetal heart. We have seen here that anything recorded below 110 beats per minute is going to be picked as an alert. So therefore, if any of these values here is say 105, going to circle that in red because that's a bradycardia. Anything that goes above 160, you're going to record and still circle it in red because it's a tachycardia, and of course take action. The taking action may involve alerting a senior midwife or a clinician or the consultant, whoever is available for that kind of action. When it comes to fetal decelerations, we have early, we have variable, we have late decelerations. Now, the one that is an alert value is a late deceleration. When you do not have any deceleration, you enter N, indicates that there were no decelerations, as is done here in this example. We have also seen the section of on amniotic fluid, where you have the patient has punctured membranes. Either you have done through artificial rupture, or she has had a spontaneous rupture. So here it's indicated as teeth. So that is for clear, just like in the old pathograph. We indicate clear, or you say intact, or you say blood stained or meconium staining. Now you see that the alert value is only for meconium staining grade 3. Again, here I need to point out that the way that, like we said, clinical judgment is still at play here. Now, you may have a client who comes with meconium staining grade 3, but that client is in second stage, is already in second stage. Therefore, what you need to do, that the action, it is good to alert here, but then your action would be to expedite delivery, if it is possible to do that vaginally. Just quickly indicate that that is notable, but then take the appropriate action and indicate down here. Now, for meconium, so now a question may be asked: what happens to meconium staining 1 or meconium staining 2+? So the recommendation is try to change the woman into a favorable position, preferably left lateral position. Give resuscitation with fluids and oxygen for this for the client with meconium staining 2+ and below. Otherwise, if you have, so you can see, as you can see for this example, initially it was clear, and then here we have a meconium +1 and meconium +1, and you can see it is not circled. Now, for fetal position, the alert values are occiput posterior or occiput transverse. And occiput anterior position is okay. That is where you expect normal labor that's the cause of normal labor. So where you have an occiput posterior, which we all know that rotations can happen until you come, like what you can see here, until you come to an occiput anterior. So you alert and see your action. Say maybe you are going to allow time, or you're going to say this and that, or whichever action you take. Of course, work in collaboration with the teams that are there. Consult, talk to your senior midwife, talk to your team leader, talk to your clinician or your consultant. For caput, again, 3+ is what is an alert value. Any +2 and below, that is acceptable. Again, also for molding, it's 3+ that are an alert value, because it is expected that while the baby is born, a certain level of molding is acceptable. So a +1, a +2 are acceptable values. But again, I still need to remind you that if you have a plus a plus of 2, and maybe you have a caput of 3+, then maybe you would want to consult further and find an appropriate course of action to take. So the entire graph has to be looked at as it is, not just one item. You have to look at the entire graph and what it is communicating. These values here for pulse rate, if you remember the old graph, we used to use dots to indicate what the values are, but now we are making entries of the actual value. So if your pulse rate is 80, you just enter 80. And of course, it is showing you here a pulse rate of above 120 should alert you. And therefore, if you enter here 124, you're going to have to circle it in red. Or if you enter 56, which is below 60, then you are going to have to circle that again and take action down the line where it shows the assessment and plan. The same case goes for the blood pressure, where we used to plot using arrows and dots. So now you make an entry for the systolic. You take your pressure and it is 145 over 101. You just make 145 here and then enter 101 down here. And of course, if it is an abnormal value according to what is shown on the alert value, circle that and indicate your action in the assessment and plan columns down below. The temperature, anything for any client falling below 35 degrees Celsius, you're going to alert. For anyone who goes above 37.5, you're going to alert. And of course, again, same case, take the necessary action. If it's a fever, of course, do what's necessary that's expected of you. Now, there is a section on contractions, and you may remember that in the old pantograph we used to shade using dots or diagonal lines or a complete shade in one of those boxes. Now, that the ones that were shaded in dots were mild contractions, and then the ones for moderate were shaded using diagonal lines, and then we had a full shade for for when you are indicating that the patient is getting strong contractions. Now, so the strength of contractions, which is measured using the duration a contraction lasts. Remember, you have to palpate that the contraction using your palm, and therefore you palpate a contraction that lasts anything below 20 seconds. Then now that is alerted, indicates that this client is getting inadequate contractions. Let us remember that this section we've already said that this is active fast stage, which begins from 5 centimeters and above, and therefore we do not expect a woman who's in labor that far to have contractions below 20. So you alert and do take the appropriate action. Are you going to advise for ambulation, or are you going to initiate an obstetric for this patient? For above 60 seconds, that is uterine hyperstimulation, and therefore, if you make an entry of 61, say, you're going to circle that, and of course, again, take the necessary action, collaborate with the teams you are with, and figure what to do. Now, so this would talk about the strength of the contraction, whether it is mild or moderate, like that. This section here, the contraction per minute, just the same thing that we used to do. You have to monitor contractions for a continuous 10 minutes for you to say this mother is getting 2 contractions in 10 minutes, or 3 contractions in 10 minutes, or whichever the number. So you enter the number, there's no shading now. You enter the actual number. If it is 3, you enter 3. If it's 2, you enter. If it's 4, you enter just what you have palpated. Now, the more important one here, down here, is this one for this section here. If you're following my cursor, this section for labor progress. The section for labor progress has the cervicogram here plotted with an X, just the same way we used to do in the old pantograph, and a descent plotted by a small O like that, like we used to do again in the old pantograph. So, but now here, there is, let us remember again, this is a guide, and therefore, when we plot for an actual patient, we must remember that this is a real patient we are dealing with. So now here on this pantograph, you see that you have 10, 9, 8, 7, 6, and 5. The reason we are beginning at 5 has already been advanced, that labor begins in the current recommendation is that active first stage of labor is diagnosed when the woman is 5 centimeters of cervical dilatation. Now you see these values in here against the dilatation, the cervical dilatation. Now let's begin at 9 here. What you see is greater than or equal to 2 hours in the alert column. That's the alert value for a woman who comes in, she's 9 centimeters. Now, the reasoning here is this. A woman who comes in at 9 centimeters, if they are not delivered in 2 hours, then now that becomes an alert. So now you've gone, this column, you move from here, 1, 2, that's 2 hours there. It's the same thing that used to happen in the one of these from here to here represents a 1 hour difference. So if you have this woman who came at 9, 3 hours later she's not delivered, now that's an alert. So if you plot there, you're going to have to check all the other parameters, check what is wrong with the labor progress. So the same case applies for a woman who comes in at 8 and has not delivered within, she's not fully dilated at this time over 2.5 hours or 2.5 hours. So now that becomes a concern. The woman who comes at 7 centimeters should be in second stage by the time she's 3 hours. If she goes beyond there, then now you are going to have to assess and determine whether this woman has slow progress. For the same case for 5. So therefore, for example, I need to explain here that for 5 centimeters, she comes here, and therefore you're going to count 1, 2, 3, 4. Your review would be somewhere here. At this review, if you find this woman is still at 5, this is not going to be an alert. Reason being, it's not an alert because she is not yet beyond the 6 hour limit given here as an alert value. You remember that Professor Kwesi pointed out that the 1 centimeter per hour that was envisioned in the old pathograph is not realistic for some women. And therefore, here you will not be alerting here. But if you go beyond now there and then it still remains at 5, maybe by the time you are reviewing next, now that is an alert because she's stuck at 5 centimeters. Something is wrong with the way the labor is progressing. Then, so we've pointed that out. So for this one, for the descent, there is no alert value. There are women who would come, their descent is 4, they still, you check the 3 hours, 4 hours later, it still remains the same. But it is expected that the graph for descent would go down this way, but it's not, according to the guideline, there is no alert value for the descent. Now, what happens when the woman comes and she's fully dilated over here? When she is fully dilated, or you've been monitoring from here, and she's moved that way, and she's now fully dilated. So we are going to abandon the graphing on this section of the active first stage, and then move to the other section on second stage. I want to move over there, just let me use a different graph. You'll move that to the second stage. Now you look at what is
Benson
happening
will
in the
probably
second.
add you 5. Sorry,
Yes.
more minutes. We'll
Sure,
add you
sure.
5 more minutes so that you're able to finish your end so that we can go to the next. Thank you.
I'm actually finishing. So you remove this woman from here, and then go to the second stage. Transfer the details to the second stage of monitoring, and then that's why I want to use this one. Would see here that this one is for, you have 3 columns in the second stage here, this one here. The reasoning there is for primary para, for women who are gravida, they can last up to 3 hours according to this guideline in labor, in the second stage of labor. For para 1 plus, they you have to monitor. It's expected that they can stay up to 2 hours according to the guideline. So this is the reason why you have that section. That's why you have that section with 3 columns. So you move there and then do your monitoring on that end. And then there is a section where you're going to indicate delivery. So here, now down here, see here what is indicated here. So this section, you continue your monitoring, you still indicate, and then indicate. So when the woman goes in second stage, enter here that she started pushing with that P shown there. And then down here you have, of course, the descent, you finish with it. That is how far the work, this to demonstrate this needs a lot of time. So, and because of time, I'm going to stop there and invite my colleague Otonda, who has been very instrumental in leading this work, the implementation, and even where we are from when we started using this care guide in our KNH labor ward. Then he talks about the steps moving ahead. So Mr. Tonda is a registered midwife who works with me in labor ward, and he also wears a second hat as the vice chairperson of Midwifery Association of Kenya, and he's done a lot of exploits in this section. So I'll invite him to continue. Mr. Tonda, please.
Thank you so much, Benson, for that very elaborate demonstration of plotting of the guide. Just because of time, can you kindly put down your presentation so that I can share?
Sure, shortly.
So briefly, I'm going to take you through the various steps that Kenyatta National Hospital has taken in making the transition from pantograph to the guide, the various steps that we have taken to make a seamless transition.
Are you able to share your screen? Or you could just start off as the screen is coming up due to time.
Are you able to see?
Yes. Make it in slideshow.
it?
Not yet. From the beginning, slideshow can go to the beginning.
Okay. We able to see?
Yeah.
Thank you so much. We've had an elaborate discussion so far, and KNH, we are in our third year of implementation. We've done 2 years. That is the institution of financial years 2024, 2025, 2025, 2026. And some of the strategies that we put in place to ensure a smooth transition from the pantograph into the guide. One was stakeholders engagement, where we had to involve the obstetricians, the midwives, the nurses, the administrators, and even the patients. We conducted sensitization meetings just to bring the midwives to par with the tool. And we also established an implementation task or committee that is chaired, co-chaired with the facility, the unit head of department and the midwifery team. We also had a capacity building and trainings. We did an OJT, that is on-job training, a number of continuous medical education and webinars on the guide. We also emphasized on respectful maternity care, that is during our usual handing over sessions. We also customized the tool to our local context. If you look at the bit of summary of, if you can remember the summary of the guide that Nyankuru has just presented, when you look at the labor summary, there is no slot for date of delivery, time of delivery, whoever has conducted the delivery, and also the vital signs observation after the delivery. So we have customized the tool so that we could have these slots in the guide as well. Integration into existing systems. We actually had our document first go through the process of the KNH process of approvals. And we also in the system, in the steps of making, transitioning from paper to paperless, so that we will have this tool also put into our system so that we can have real-time monitoring of mothers in labor. Another bit is monitoring and supervision. Through the Committee of Labor Care Guide implementation, we conduct a number of audits. Usually in every third quarter, we do an audit, and we also do supervisions so that we ensure that they are accurately and systemically filled. The reasons why we conduct audits, you realize when the care guide was brought into perspective, that was almost 7 years ago, and we took it like 3 years back. So to ensure that we meeting the expectations of WHO, we usually conduct audits so that we ensure that the facility users or the caregiver users are able to plot accurately, also to make decisions accurately in a timely manner, and also bring in the aspect of teamwork. Quality improvement initiative through the committee. The QI projects on labor outcomes using the labor data, the labor care guide data. We usually review our audits, we review the tools, how they have been used, so that we can improve on quality of monitoring of our mothers. We also initiate the Plan, Do, Study Act, usually after every financial year, through the audits that we've conducted, through the various labor care guides that we've conducted. We usually look at the feasibility, the acceptability, and the usability of this particular tool. Are we using it in the right way? Are we filling it in the correct way? So that when we finally accept the usage of this guide in monitoring mothers in labor, then we all our midwives, all our obstetricians are able to plot accurately on this guide. Community and patient involvement through the NC clinics during health education, we usually enhance respectful maternity care, elaborate to our mothers why it is necessary to have companions during delivery or while they are in labor. We also promote shared decision-making and respectful maternity care during this particular period in our antenatal visits or in our antenatal clinics. Our policy and leadership support, we've had very good support from our leaders, as you can see from the webinar today. Our head of department, Dr. Ende, is here. We have Dr. James Amenge is also here with us, who are our leads in the unit to support the entire process of initiation or transitioning from partograph to labor care guide. So once you have a strong leadership support, you all have the systems that could be working for this guide. Resource mobilization. In certain sections of monitoring, you realize you'll require certain resources. For example, when you're looking at fetal deceleration, sometimes you'll require a CTG machine, you require a fetal Doppler, so that you're able to accurately get decelerations during contractions, which sometimes you might not be able to get via auscultation. Also, we mobilize for funds for trainings, materials, and for supervision purposes. The data that we collect through audits, we usually relay to the head of department, which is finally relayed to the CEO, so that we are able to make a unanimous decision whether to adapt the tool or not, keeping in mind that the tool improves intrapartum care. We also track key indicators like cesarean section rates and the patient satisfaction. In as much as we are in the implementation phase, we do have various recommendations that we felt as a facility or as an institution that would help in the transition of partograph to the guide. One, WHO labor guide should be universally adopted and used in monitoring of labor in all settings to improve intramatern care. Secondly, health system should give every labor care provider adequate training use of labor care guide so that it ensures effective use. And then also labor ward should be adequately staffed. I can see in the comment sections colleagues concerned about quantity and quality of work regarding the number of patients and the number of midwives, that is the midwife patient ratio, mother ratio. So it should be adequately staffed so that as we adopt the tool, all the conditions that make the guide for usage are adapted. And also in settings where labor care guide is unavailable or staffs have not yet been trained on the guide, should be given opportunity to continue using the partograph so that we don't have gaps in monitoring of mothers, and also to get good outcomes in terms of delivery, both to the mother and the baby. So those are some of the initiatives that we put in place as an institution so that we are able to transit from the guide, from the partograph into the guide seamlessly. So far, we've started our third year, and what we are implementing at this bit is looking at the usability, the feasibility, and the acceptability of this tool amongst the midwives. In terms of outcomes, we will look at that after we are able to ascertain that all our midwives, all our obstetricians are able to effectively use this particular tool. Thank you.
Thank you so much, Jack. Utonda, that's a wonderful presentation. Team, that's a great work done. And we'll have just 2 or 3 minutes by Dr. Wende to just give from a leadership perspective how the process has been. Then she will hand over to Dr. Nyanjao to give a way forward from the ministry. I have to apologize, we may not have much time to be able to answer live some of the questions that are going to come up on the wall, but we are making efforts to answer to them. At this point, just allow me to appreciate everybody who has participated in this, beginning from Dr. Mary Maina's mail to the ministry requesting on this labor care guide sensitization and the ministry's quick action, and Ken H taking leadership on this part. And Dr. Wende, we appreciate so much the magnanimity that you did consider to take leadership in this national sensitization. So over to you, Dr. Wende. When you are done, I'll probably ask you to hand over to Dr. Nyanjao to give MOH way forward. Thank you. Over to you.
Thank you very much, Dr. Menge. I'd like to sincerely thank everyone, especially the Ministry of Health, Ramka leadership, our colleagues from the University of Nairobi, and our dedicated Kenyatta National Hospital obstetricians and midwives for their valuable contributions to today's session. So our experience has been largely summarized by Mr. Otonda. I'm just going to give a few adds that really our journey with the labor care guide has been very structured and intentional, and its use has been formally embedded into our performance framework and it's been included in the Director of Nursing Services Performance Contract, after which it is cascaded to the departmental nursing leadership and individual midwives. And this has ensured accountability, consistency, as you have heard from Mr. Otonda, and ownership. Therefore, the implementation has been a true team effort, but I must emphasize that our midwives have been the heartbeat of this initiative in the implementation of the labor care guide. They're the ones who bring the tool to life at the bedside by monitoring our patients, documenting, interpreting, working together with the doctors, because being a level 6 facility, it is mainly consultant-led, but we also have residents and, of course, our midwives. So they work collaboratively in interpreting and making timely decisions. So their commitment, even amidst very heavy workload sometimes, like we experienced recently, it has sustained the gains we've made and anchored respectful, evidence-based intrapartum care. We've also worked very closely with the Department of Healthcare Quality. I know one of them was in the meeting, but in the interest of time, I'd wanted her to make a few remarks, but I will not do that because of time. And we've also worked with planning. We have been monitoring the tool, and our latest audit was in the third quarter of 2024-2025 financial year. And we reviewed about 200 files and reviewed 63 medical teams. And we found that, confirmed that 100% adoption of the labor care guide across all cases. And this, I think, is a major milestone in standardizing documentation and care. And the findings, I know it's not all perfect. We have challenges. The findings from this audit identified some opportunities to strengthen completeness of entries, accuracy, and also supportive supervision, which has been entrenched in this process. So the insights from these audits have also guided targeted mentorship, as you have heard from Mr. Otonda, and also continuous professional development. We had one last week, we are having one today, and as well as leadership advocacy, because we have used this tool to advocate for additional nurses for our labor ward. Because when you have, say, a tool that is not completed well, then usually you must show reasons why this is happening. So as we move forward, as a hospital, Kenyatta National Hospital is advancing towards digitization of the labor care guide, where plotting is going to be real time with timestamps. And when we have timestamps, it enhances accuracy, it enhances accountability and timely decision making. So overall, we've observed that the labor care guide enhances clinical decision making, team communication, and timely intervention. It has contributed to earlier recognition of complication. As you have seen, it is much clearer than what we had before. It has also, I think, contributed largely to improved maternal and neonatal outcome amongst other intervention within our facility. So we are requesting that referring facility also use this tool when you're referring patients to us or even to other levels of care. Please use this tool. It's a very good document for referral so that we are able to comprehensively assess the care that the patient has received in the facilities that are referring. So thank you very much for your time, for joining us this evening, and the Ministry of Health for giving us the platform to share this knowledge and experience from Kenyatta National Hospital. Over to you, Dr. Nyanjao. Thank you very much.
Thank you so much, Dr. Wende and all the speakers, and even more thanks to our audience for your active participation, for all the questions and the remarks and the reflections. And I am really encouraged by the appetite we can see, and we will try to keep up with that energy. As a way forward, and as alluded to by Dr. Serem, the head of division of RAMCA, we want to move with speed and roll this tool for use at all service points. Some facilities and some counties are already ahead of us, and we are very happy with that, and we will ride on that knowledge and the learning that they have been able to obtain in the course of time. So as a way forward, as a ministry, we know we cannot do this on our own, so we will start out by mobilizing collaborations amongst all the stakeholders who are interested in maternal health to join us in this journey of rolling out this tool to all facilities. We will then develop a pool of trainers, especially from the facilities that are already implementing this tool. We want to move from the known to the unknown. So we will use, develop that. We will develop that pool of trainers who will then use to cascade all the training to every single one of the healthcare providers. We will also ride on the existing champions. I know there are some here and others who may not have been able to join us today, and then recruit more champions to keep mentoring the users, both on the supply side, that is our healthcare providers, but also generate demand by educating our mothers, either currently gravid or future mothers, that the monitoring expectations during labor may change over time, and we would lean on their patients to work with us so that we improve the service. So anticipate quite a bit of engagement. Training will come. Training will come, not all as we expect. Some of it may be virtual, some of it may be in person within your facilities. So let us be flexible and let us look forward to all these resources that will come our way. Thank you so much. Over to you, Dr. Amenge.
Thank you. Thank you so much. Thank you, every one of us who is present here. This has been an amazing platform, amazing learning, 1,300 and above participants. The eagerness to learn from this, I think, has just been an amazing, amazing, amazing experience. Ladies and gentlemen, we have to translate lessons to bedside, and that's what makes the difference in our patients' outcome. And I think that's our biggest dream. So let's collaborate, work together. And with that, I'm certain that we get more communication, invitations, platforms for sharing, and definitely we acknowledge that there's a need, and this must be this is a challenge the ministry, that Labor Care Guide is going to open a Pandora's box for healthcare, human resource for healthcare, and we can never run away from it. So we have to brace ourselves on how to reorganize, make ourselves efficient, and have the right numbers, right attitudes, right culture to be able to really make a meaningful, respectful maternal care to our pregnant women who are in labor. With that, ladies and gentlemen, allow me to ask each one of us individually to join in the grace. And so may the grace of our Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with us now and forevermore. Amen. Be blessed, everyone. Create a change wherever you are. Thank you. Thank you, everyone.
Thank you very much and have a good night.
Thank you and good night.